Good morning, everybody. It's a pleasure to be here, an honor to be able to spend a little bit of time with you from the podium. And I'm going to talk about this era of surgical endoscopy, and I hope to illustrate through this brief talk the impact that Jeff has had, not only on the things we've already heard about kind of ushering in this modern era of surgical endoscopy, but how through his work and influence, through many of us in the room, has promoted that era and advanced it to the betterment of patient care. So as Rob alluded to, when we were given some notes about how to prepare for this program, many of us were given a line out of Jeff's CV that was something to kind of prompt us to talk around. And this was the line I was given, August 2005, a course at Ethicon's headquarters in Cincinnati. And he was given a talk called, "Why Should Surgeons Do Flexible Endoscopy?" And when I was looking at this and kind of ruminating on what I would speak about and how I would use this, it made me look a few pages up in that CV for another line that I knew would be there, and it was this one. August 1996, same location, same course. Jeff was course chair at this one, but the reason why I connected the two was that this course that I attended as a newly minted therapeutic endoscopy fellow with Jeff, his first one-year fellow. I don't know if that reflects a milestone in the advancement of the fellowship or a reflection of my need for a longer training period, but I was the first one-year fellow. And the reason why I wanted to bring this up is that the impact that this experience had on me, I believe, is the same that being in a teaching environment with Jeff had on many of us, and that has fostered this field of therapeutic endoscopy. And in the spirit of just do it, I wasn't along for the ride just to be at the course. He put me in the lab to instruct at the course with a whole month of fellowship under my belt to really do that with authority. So what did we learn as an endoscopic community about these kinds of interactions? Well, first of all, why should surgeons do endoscopy? I was pretty invested in hearing the answer to this since I had just committed to a year of additional training to do this, and I was blown away with what I heard. I heard that, well, it's what we do. It's what surgeons do. In fact, we have a long legacy in flexible endoscopy. And you heard this from Tolga early. Many of the things, and I would argue most of the therapeutic endoscopy interventions that are done today were first described and performed by surgeons. And that has transformed healthcare. This one in particular caught my eye. So this is McCune, Shorb, and Moskowitz, three physicians at George Washington University, a place where I did my surgical training, describing the world's first ERCP, an advanced endoscopic procedure not to look inside the intestine, but to look at organs adjacent to the intestine, into the bile ducts and into the pancreas ducts. And it was because of the middle name there, Dr. Shorb, Dr. Paul Shorb. I trained with 7 years with Dr. Paul Shorb. Not once did I hear about his role in ERCP. I was blown away that actually I had interacted with a part of the history of this surgical endoscopy and didn't know it. This is a picture of Dr. Shorb in 2005 when I was invited to come back and give the Shorb lectureship, and you can bet it was on therapeutic endoscopy. So I learned that surgeons have a responsibility to make surgery safer, easier, and less invasive for our patients. And that because of that responsibility, we need to pick up this scope and advance the field of surgery, to move it from to move it from open surgery to laparoscopy to endoluminal surgery. And if you don't believe that movement's been happening, then you haven't been paying attention. Because this is a list of disease states that when I started my surgical training, most of which were managed with surgery, today every one of them is managed with endoscopy. So if you want to be a GI surgeon, I tell my trainees, you look at the shrinking list of surgery and the growing list of endoscopy for the things done in the GI tract, you better pick up that scope. We also learned that we have an obligation to teach others. And that has been a foundation of my career personally. And we learned not only about how to teach, but we learned how to create environments to do that teaching. When I was in Cincinnati, I had never been in a lab like that. I had never seen the sophisticated, simulated environment where you could rehearse procedures in a way that made you ready to go back to the real clinical environment. I learned from Jeff how to create those environments in other places. I saw him do it at Mount Sinai. I saw him do it at Case Western. An important part of the case was you learned how to use resources that were available to you. You heard that he closed off a hallway to create the lab. That's just get the work done. Just do it. I had the privilege of going around the world to other laboratories to see ones like this in Urcad in Strasbourg, France, an unparalleled training institute with sophisticated ways to teach others how to do what we do. And I took those learnings back to Houston, Texas when I was there to build our own facility. And when I left that facility in 2019, we were training over 6,500 healthcare professionals, practicing healthcare professionals, on new techniques and new technology to help bring them to their practice. We also learned that this education has a magnifying effect. That as a clinician, I treat one patient at a time, and that's a special interaction and a privilege. But as an educator, the people that I can help teach the things that we do, they impact larger patients, and that has an amazing magnifying effect. We learn to take that magnifying effect to societies. And I have to say, it warms my heart that next month at the American College of Surgeons meetings, there are 16 courses that are hands-on training programs. 4 of them are on flexible endoscopy, 25%. Jeff Marks, you'll remember it wasn't so long ago where you proposed to the college that they do a course, a hands-on flex endo training course, and they turned you down. It took a few proposals over the years to get to this stage. Surgeons are living in the era of surgical endoscopy. We also learned that we had to measure performance better. We had to assure ourselves that people were learning the things that they needed to know and do in order to do these techniques better. That led to the development of programs like this. This is the Fundamentals of Endoscopic Surgery. It is a test of knowledge and skill in flexible endoscopy. In fact, it's the first and only computer-based simulation test that is required by the American Board of Surgery for your certification. And my guess is we'll hear more from that by John Mellinger in a little bit. We created report cards on the performance of endoscopy. This is a tool where I can walk into an endoscopy suite, watch a clinician perform an upper or lower endoscopy, and give them a score that correlates with their proficiency. And we leverage this background to create more modern frameworks of training, partnering with education experts to leverage the science of education, a science that is advanced every bit as much as the science of medicine, in order to teach better, to accelerate procedural adoption, and to get these techniques and technologies to our patients quicker, safer, and create less invasive paradigms. We also learned about the importance of collaboration with industry. I remember very clearly, I was a newly elected member of the board at SAGES, and in front of the board was a document that we were drafting that was to guide surgeons on how we should interact with industry. And when I was reading through this document, through the draft, it seemed very draconian to me. It wasn't reflecting what I had seen in working with Jeff and his interaction with industry, how that was respectful, thoughtful, enthusiastic, and patient-focused, and it led to the development of new technology for the betterment of patients. And I was worried that this document was going to put up barriers in that collaboration. But I have to say, I was a new member of the board. I didn't really know what my place was. I certainly wasn't a voice within the society. But I remembered that interaction that Jeff had demonstrated to us and summoned the courage to speak up, and it helped to modify this document. And I believe that that not only created a better guideline, but also was part of my trajectory in the leadership in that organization. And he also told us and taught us how to collaborate with our GI colleagues, that we're not enemies, that when we work together, patients benefit, and by the way, we have a heck of a lot more fun. And I have to say that I've had the honor of working at 4 different academic institutions, every one of which, when I walked into the door of those institutions, I was met with skepticism by the gastroenterology community there. And when it came time for me to walk out of the door of those institutions, that was met with sadness because of the loss of collaboration that we had and that we had developed over years. And that's been a true treasure of mine throughout my career. So the era of surgical endoscopy and the things that many of us were taught, like in those courses in Cincinnati, where it was our responsibility to advance the field of surgery by picking up a flexible endoscope and advancing endoluminal surgery. We were also responsible in teaching others how to do that and leverage that magnifying effect, and we need to collaborate with our industry partners and our professional partners for the betterment of patient care. And let me just say in closing, we all know Jeff's fondness for all things Western, horses and wear and that kind of thing. And so I thought it was fitting to choose an image of a cowboy riding off into the sunset, not into the sunset of life, but into the sunset of career, at this stage of the career, I would say. And there's an old cowboy proverb that says a cowboy is a gentleman with or without his hat and boots. And I've modified this proverb to something that I think is appropriate to today, and Jeff, and particularly to you, and that is a surgeon is a leader with or without his mask and gloves. So thank you again for allowing me to be here. What a special opportunity, and congratulations.
One little anecdote about Jeffrey. He was recruited to go from, I think,